There's a number of guidelines out there for obesity. There's the one I'll be talking about, the AACE evidence-based guidelines, which is very comprehensive, all aspects of obesity care. The Endocrine Society, which is kind of focused on pharmacotherapy, and I think they made a contribution pointing out iatrogenic causes of obesity, some of the medicines we use for other diseases. There's the AHA, ACC, TOS. This was even before pharmacotherapy was really, we had more options, so they really concentrated on lifestyle and surgery. There's the Obesity Medical Association. This is just online. It wasn't kind of a peer-reviewed journal, but a very comprehensive and holistic approach to obesity. There's the NICE, the United Kingdom National Institute guidelines on obesity as well. In India, we had the 2009 consensus statement, which really kind of established India-specific criteria for diagnosis, both BMI and waist, but also discussed treatment of obesity, I think, in the context of preventing complications such as diabetes and cardiovascular disease. In addition, there's been a number of other kind of reviews and recommendations for obesity by my Indian colleagues that have appeared in journals, a number of those as well. All of these guidelines, they can fall along this spectrum. On one end, you have BMI-centric algorithms where treatment indications are based on BMI, and the goal of therapy is to lose a given amount of weight. On the other end of the spectrum are complication-specific guidelines, where treatment indications are based on risk, presence, and severity of complications. And the goal of therapy is to treat or prevent those complications. So these guidelines kind of spread themselves off along those that spectrum. But there's differences, you know, I think on one end you'll be treating all who meet the BMI criteria. On the other end, you're going to use more aggressive treatments for those who will derive the highest benefit, those with complications. That alters the benefit-risk ratio and the cost-effectiveness of the interaction. It's the NHLBI, I think they're the most BMI-centric. You can see the BMI categories, the lifestyle, pharmacotherapy, and surgery treatment options. You see the no's, you see the yeses. You get the idea. It's the BMI category that really determines indications for different treatment modalities to a large extent. And we'll see that the AACE guidelines will be more on the complication-specific side of the equation. So let me begin at the beginning. I think we began by acknowledging there's a paradox. We have more effective tools than ever before to treat obesity, but yet these diseases are resulting in increasing amounts of suffering and social cost, both overweight and obesity, and all patients have limited availability and access to many effective evidence-based therapies. So what's that all about? Well, it's been 5 years ago now that AACE convened this consensus conference on obesity, inviting just not biomedical and clinical people, but representatives of all stakeholders in society that need to work together in a concerted way to solve this problem. These are the pillars, if you were, that support the concerted action plan for obesity. And all of these people from their different perspective, biomedical, government, regulatory, healthcare industry, research, education, address these 5 questions on the right. It's very interesting to hear different perspectives on these, and then we came together and discussed these answers to these questions and together to see what the difference in perspectives were, trying to achieve some consensus. And it did lead to a number of affirmed concepts where, you know, we kind of agreed on stuff we kind of thought we'd agree on. But also some emergent concepts that only became apparent in the context of this multidisciplinary discussion. One of those emergent concepts was the definition of obesity was really inadequate. The imprecision and uncertainties regarding a medically meaningful definition of obesity emerged as a major impediment to concerted action and was responsible for immobilization across these pillars. It was recognized that BMI really didn't tell you much about how things were affecting the health of the patient, and it was thought that the framework for a medical definition of obesity would consist, let's use BMI, but let's bring it together with an assessment of obesity-related complications. So, we felt we needed two components to the diagnosis, not only the anthropometric measure, some indication of adipose tissue mass, but also the indication on the impact on health of that increase in adiposity. And, BMI was here to stay. It's not a perfect measure of adiposity. It only interrelates height and weight. But then we also needed a surveillance for the presence and severity of weight-related complications. So two components to the diagnosis. And with that in mind, the Executive Committee of AACE put forth a mandate, and that was to establish evidence-based care model, evidence-based guidelines that fulfilled these criteria. It should be comprehensive, addressing all aspects of diagnosis, evaluation, treatment, practical, applicable to real-world patient care, evidence-based. So consider that AACE not only just looks at the randomized clinical trials, but considers the totality of evidence pertinent to all key aspects of patient management. We then look at that evidence, make recommendations based on that evidence, but then adjust the strength of those recommendations according to the strength of the evidence. And finally, guidelines are designed to optimize benefit and risk based on defined outcomes that reflect the impact of treatment on the health of the patient. And so a task force of writers was put together by the executive board, nominated, and this group worked pretty hard, and these guidelines were published in Endocrine Practice in 2016. And basically, there were 9 broad questions that the committee put forth, and data was gathered around these 9 main questions that fell into these categories: what are we treating, why are we treating it, and how do we treat it? And then each of these 9 questions had a number of other sub-questions, and all of this led to 123 evidence-based recommendations addressing all aspects of obesity care. Again, these recommendations, some were stronger than others. Most of them were grade A, really requiring randomized clinical trials, but are grade B. So a lot of high level of evidence here. But the recommendations, the strength, were adjudicated by the strength of the evidence available, the totality of the evidence. And just by just one item of background here, one question we put forth to the task force was, do the 3 phases of chronic disease, the classic phases of prevention and treatment, primary, secondary, and tertiary, does this apply to the disease of obesity? And the recommendation there, which was a grade C, there's no randomized clinical trials on this, was that the modality and intensity of obesity intervention should be based on the primary, secondary, and tertiary phases of disease prevention. This 3-phase program for chronic disease aligns with the pathophysiology and natural history of obesity and provides a rational framework for appropriate treatment at each phase of prevention. And this is consistent with the natural history, as I said. If in the absence of obesity, say we're lean, we're still living in an obesogenic environment. We need primary prevention to prevent the disease from happening in the first place, particularly those at genetic and environmental risk. But in many patients, these obesity susceptibility genes will interact with behavior, environment, other biomedical conditions, and produce obesity. Initially uncomplicated in many patients. At this point, we're into a secondary prevention mode. We need to prevent further weight gain and prevent the emergence of complications. But then there are other, perhaps overlapping subsets of genes that interact with environment in different ways that determine how severe the disease will be and whether it will be associated with complications and how severe those complications might be. Then you're in a tertiary prevention mode. You've got to really step up your game, be more aggressive, prevent further disease deterioration, induce some weight loss, particularly to address those complications that can be improved by weight loss, and treat these complications. So these are kind of an underpinning of these guidelines, this chronic disease model. So here's kind of a one-slide summary of all the guidelines. I don't want you to read everything that's in here, but these different steps do conform to this: what are we treating, why are we treating it, how do we treat it paradigm. And at the top, we have what are we treating, which is diagnosis, which is both the clinical and anthropometric component. And then that information is used to stage the disease. Stage 0 if there's no complications, 1 if there's mild to moderate complications, stage 2 with severe complications. And then that information kind of tells you why we are treating it and tells you kind of is a guide to the modality and intensity of therapy you want to bring to the table for your patient. And then how we treat it is again based on a disease stage, whether we use structured lifestyle intervention, medications, or bariatric surgery. And then the goals of therapy are not to lose X amount of weight, but to treat or prevent those complications, because it's those complications that confer morbidity and mortality, those complications that impair the health of the patient. So let's go through this in a little bit more detail. What are we treating? Screening, diagnosis, and staging. Here's one question and one recommendation, number 29. Do BMI or other measures of adiposity convey full information regarding the impact of excess body weight on health? And the response here with grade A evidence was that all patients with overweight or obesity should be clinically evaluated for weight-related complications because BMI alone is not sufficient to indicate the impact of excess adiposity on health. And therefore, the diagnostic evaluation should include both an anthropometric and a clinical assessment of weight-related complications. So the anthropometric component, you know, we use BMI. Annual BMI determinations are advisable. We use, you know, ethnic and regional criteria cutoffs for what constitutes a high BMI and a high waist circumference. But remember, a BMI just interrelates height and weight. And I think clinically you need to take a quick look at the patient with a high BMI and make sure that that high BMI represents increased adiposity. I have a slide I didn't include, which is kind of a disturbing image. And on one side, you've got Conan the Barbarian with all these muscles. And on the other slide, you got a gentleman with a kind of a beer belly and a Speedo swimming suit. They both have the same BMI. One's due to muscularity, the other was due to fat mass. So you got to interpret the BMI just like any other clinical test. And then bring into play the clinical component, a screen for some of these complications on the right. This doesn't involve a heroic effort. This can be done in the context of an initial patient examination with a history, obesity-focused history, obesity-focused review of systems, physical exam, and standard laboratory. You can get a pretty good idea of whether these conditions are present or not, these complications. Some may require more evaluation, but this doesn't require something that's going to go on for weeks and months. This can be done in the initial examination. And then use this to stage the patient, overweight or obesity, secondary or in a secondary prevention mode. But once you have complications, that tells you that adiposity, whether it's a BMI of 25 or 35, is sufficient to impair health. And you're in stage 1 with mild to moderate. Stage 2 with severe, you're in a tertiary treatment mode. The guidelines do kind of suggest this checklist here for a screening of patients for the complications and kind of what it takes to get an idea of whether these exist or not, mainly involving exam, review of systems, exam, and some standard laboratory. I also want to refer you to the AACE Obesity Resource Center. This is online, obesity.ace.com. There's a lot of resources there for patients in obesity medicine, focused, obesity-focused review of systems that a patient can fill out a form while waiting in the office or fill out online before they come in for their visit. Other tools that are there for your perusal. And also our new proposal that the diagnostic term for obesity, not the lay use, but for the diagnostic medical terminology should be, we're proposing adiposity-based chronic disease, which is more medically accurate and actionable. Adiposity-based because it involves abnormalities in the mass distribution and function of tissue, and chronic disease It's a lifelong disease. You got complications. And we, as I mentioned, the natural history is consistent with opportunities for primary, secondary, and tertiary prevention. So why are we treating it? What are our treatment goals, okay? Well, like I said, it's to improve the health of the patient and to prevent or treat weight-related complications that do impair the health of the patient. So you've got your 3 stages, 0, 1, and 2, and the goals are there, as I've kind of already alluded to. Secondary, you want to prevent further weight gain and complications. Tertiary, for stage 1 and 2, you want to stop, you want to get some weight off, and you want to treat those complications. Yesterday we talked about this dose-response relationship between how much weight loss you need to achieve to improve different complications, and it varies as a function of the complication. Diabetes prevention, 10% is maximally effective. I'll talk about that tomorrow. Hypertension, dyslipidemia, hemoglobin A1C, and diabetes, the more the better. 15% or more is better than 5%. Non-alcoholic fatty liver disease, 5 to 10% gets fat out of the liver, 10 to 40% stops fibrosis and inflammation. And you have other sleep apnea, as I talked about yesterday. You really need 10% to get predictable improvements in the apnea-hypopnea index. So your goal of therapy is to kind of get sufficient weight loss to treat or prevent these complications. This is just a slide, a partial slide from a figure in the algorithm. It lists these clinical components, what the intervention weight loss goal is, and what the clinical outcomes goals are. I don't want to go into detail, but just refer you to the algorithm and the website for this information. All right, how should we treat it? What's the therapeutic plan? There's 3 major modalities that support our care of patients with the disease of obesity. We advise, based on data, treatment that's according to disease severity. If you have in a secondary treatment mode, perhaps a structured lifestyle intervention may be sufficient in many patients. If there's stage 1 disease with complications, mild to moderate, think about adding a weight loss medication to the lifestyle. And with severe complications, you really need to use medications, intensive lifestyle, consider bariatric surgery. For lifestyle management, we've heard some of this today. There's 3 components. There's the meal plan. We don't even use the word diet. We say meal plan. There's a number of those that are perfectly useful depending on personal and cultural preferences. Low carb, volumetrics, DASH diet, Mediterranean diet, very low calorie diet. But the idea is to give the patient a meal plan to which they can adhere and present it in a reduced calorie format. Many randomized clinical trials show that meal replacements, steaks, bars, add structure to the diet, take the guesswork out of calories, and facilitate weight loss. We also have a very low calorie option as well. Physical activity, the guidelines all say 150 minutes a week of moderate exercise. I don't know about you, but I have some patients that can't do that. They also say that aerobic and resistance together is better than anyone alone. But as I said, some patients can't rise to this equation. They may have too high a degree of obesity, may have other disabilities, osteoarthritis, etc. But research also shows that anything is better than nothing. So you start them off slow, build up gradually. An exercise prescription is what we give them based on what their preferences are. And then finally, there's the behavioral component. We've heard about that today, which is a package of interventions which really are intended to enhance adherence to the reduced calorie meal plan, whether that's just self-monitoring, self-recording of food, activity, weight, whether that's motivational interviewing, whether that's positive thinking, as we just heard about. We also screen patients for depression and binge eating syndrome, which is more common than you think in patients with obesity. Some of these patients we bring in as clinical psychologists. If you don't deal with these problems right up front, the effectiveness of your lifestyle intervention won't be as good. The medications, I've talked more about this yesterday. Here's our medications that are approved for the chronic treatment of obesity. Phentermine is only approved for, as a single agent, only approved for short term, 3 months or so. But these are the medications we have available. And as I indicated yesterday, these medications attack the very pathophysiological mechanisms that lead to increased adipose tissue mass and sustain that adipose tissue mass even after weight loss interventions. They're working against the patient. So these drugs help with those processes. Here we're seeing these drugs interact with these POMC neurons in the hypothalamus, increasing secretion of alpha MSH, binding the MC4R receptor, signaling to higher cortical centers. This is the anorexigenic pathway, making you eat less. When do you use these medications? This is from the algorithm. Think about initiating lifestyle therapy if there's no complications, or if there's mild to moderate complications where you think you can get sufficient weight loss to address them. That's on the left there. But consider medication strongly if there's a failure on lifestyle therapy or weight regain with lifestyle therapy, but most importantly, in the presence of weight-related complications where you need that weight loss. Anytime you add these medications to a lifestyle intervention, you get more weight loss and keep it off for a longer period of time. So help your patients out, you know? They're working hard, you're working hard. Let's enjoy some success. And then finally, follow-up and goals. Again, the goals here are to improve these complications. This is a chronic disease, a lifelong disease, where we need to commit ourselves to chronic extended therapy and really follow our patients for the improvements in health and optimizing their health to the extent possible. This complication-centric approach is kind of reflected in the diabetes guidelines of AACE as well. Here's the prediabetes algorithm. You can see that yellow bar across the top. Lifestyle therapy, including medicine-assisted weight loss, appropriate to treat the cardiovascular risk factors, the dysglycemia, and the diabetes prevention. And also the diabetes guidelines themselves. You know, AACE has these hierarchies of drug preferences based on the entry hemoglobin A1C level. But there's that little yellow bar across the top. Maybe other people that show this slide aren't going to point that out to you, but it's there. And it says lifestyle therapy, including medicine-assisted weight loss, appropriate at all phases of diabetes progression. And tomorrow I'll talk about the effectiveness of weight loss therapy in diabetes prevention and diabetes, and the excellent therapeutic profile that this weight-centric approach, in addition to a glycemic-centric approach, can bring to help our patients. In individualizing therapy, you know, we have to consider patient factors, biological factors, pharmacotherapy factors. You know, this was another question and recommendation. Are there differences in weight loss drug efficacy and safety? And the recommendation number 80 was, you know, you need to individualize care. The optimal weight loss medication for each patient, you need to consider differences in efficacy, side effects, cautions, warnings, as well as the presence of weight-related complications, which ones does the patient have, and other aspects of the medical history and comorbidities. And these factors are the basis for individualizing weight loss pharmacotherapy. You kind of have to be a good doctor, I guess. But a generalized hierarchical algorithm for medication preferences that would be applicable to all patients. In other words, this drug is the best for all patients. That cannot currently be scientifically justified. The algorithms, we have these pages that list all of the drugs here, mechanism of action, dose, side effects, warnings, other monitoring, comments, tips to help individualize therapy. And I'm just referring you to those here. I'm not going to go over these in detail. Likewise, we address comorbidities that the patient might have, you know, chronic kidney disease, cardiovascular disease, nephrolithiasis, depression, and which of the drugs approved for chronic care may be preferable in those particular settings. Again, I just want to alert you to the presence of these tools And there's also an interactive algorithm. That big algorithm that I showed you, there's an interactive format here where you can click on these different components, and then click on some other components, and try to kind of pursue what is best appropriate for your individual patient. So I'm going to summarize here. We started 21 minutes late, but I'm picking up about 5 minutes here, so thank you very much. In summary, the AACE guidelines, they constitute an evidence-based model for patient care that encompasses all aspects of real-world care: screening, diagnosis, staging, treatment decision, goals of therapy, follow-up. They establish a diagnostic approach that incorporates both an assessment of adiposity and the impact of that adiposity on health, and you know that's the weight-related complications. And you know, these algorithms and guidelines, they're just guides to assist you in your clinical judgment, but they guide the treatment modality and intensity based on the phases of chronic disease prevention and treatment, and establish desired outcomes and goals of therapy that don't simply reflect amount of weight loss, but improvements in patients' health, emphasizing a patient-centric approach. And I think this is a model that can rationally be adopted by healthcare systems with integration into overall portfolios of patient care. You know, if payers or healthcare systems or insurance companies or governments, you know, they're kind of fearful of unleashing and improving all these medications and lifestyle interventions and bariatric surgery for patients because the at-risk pool is so high, the disease-affected pool is so high. You know, in the United States, it's, 1/3 of the population has obesity, another third has overweight. In India, it's the BMI criteria, maybe 25%, but, you've got central adiposity as well. And so there's a high numbers of the population that are affected by this disease. Approach like this, which targets more aggressive interventions to those at higher risk, those in whom the intervention is more likely to benefit, improving benefit risk ratio, and cost effectiveness, distributing care with some alignment to those principles, I think, could be useful in kind of convincing these stakeholders that we need to really make these evidence-based therapies available to a greater extent so that we can help our patients. So thank you very much.